Hi, welcome to the Orthobiologics podcast. We are here back on season 2, episode 6, and this episode is about whether or not we need to use injections inside of the bone or whether or not we can just stay on the outside in the joint. I'm honored to be joined today by a guest on the show who is a first time guest here, Dr. Eric Gazufka. He is a PM&R doc by training who did a spine fellowship in Plattsburgh, New York, after finishing his residency in Wisconsin. He is originally from Michigan, where he went to undergrad and then also did medical school there as an osteopath at Michigan State, and is proud to work in Western Michigan with Michigan Pain Consultants, where he now offers very modern and advanced treatment with both platelet-rich plasma and bone marrow-derived stem cells, as well as other interventional options with X-ray and ultrasound guided procedures. So, Eric, thanks so much for joining us on the show today. And in particular, we're going to start talking about this paper that just came out from a guy who's on the show, Dr. Felipe Hernigo, who is a kind of what many people say is the father kind of this field of orthobiologics. And it is a paper specifically about whether people should be getting injections on the inside of the bone if they have knee arthritis or inside of the joint. So tell me, first of all, what was it about this that kind of struck you as important for how we practice this kind of medicine in the field?
Well, thanks, Trevor. It's great to be on the show. Dr. Hernigue has probably influenced almost all of us that are doing these procedures now. It was actually his earlier paper where he was using these injections into the bone, subchondral or intraosseous, we like to call them, in people that had been on high-dose steroids, and they were actually getting dead bone. And he was seeing a reduced knee replacement rates in that population. And that's really when I started to change my practice from just injecting into the joint and the extra articular structures to really start focusing on bone, probably about 3 to 4 years ago. The title of the paper is one of the things that blows your mind is, reduction of total knee arthroplasty at 15 years. It's just amazing to think about. This man had these ideas. This current study we're reviewing started in 2000. So he's definitely the godfather of the field, and he was, leading us and showing us the way of what to do with these cells and where to place them.
Yeah, and I think we've got, depends what estimates you read, but the current estimates are about 250 million people worldwide suffer from knee arthritis. We've got, different kinds of treatments because of how much disability, knee arthritis causes. And some people have estimated up to 1 to 2.5% of our whole GDP in terms of how much it costs just to treat these. Certainly a big part of that cost is end stage disease when we get to a joint replacement of the knee. But I think in particular, we've looked at a lot of therapies that help treat the symptoms, but in a lot of ways do not actually modify the disease. And so I think Dr. Hernigo and others who have embraced this approach are really looking at whether or not we can modify disease in the knee. You used a couple of terms in particular I want to focus on. You kind of said intraosseous, you said something else, extra articular. Let's define a couple things at the start of the show so that it's clear for the people who listen. Tell me what you mean exactly by synovium, and tell me what you mean by subchondral bone. What do those things mean?
Well, classically, when I went through my training, we were taught arthritis. When you look on an X-ray, you see a few different things, but the main point that was hammered home, it was cartilage loss. That's what's causing the pain. And if you have cartilage loss, there's not too much that we can do for the patients. If it's moderate to severe, they're looking to a joint replacement. But what we've found over time is there's a lot of painful structures that are in the joint, outside of the joint, connected to the joint, be it ligaments, tendons, muscles, nerve endings, or the bone itself. So what we're really starting to appreciate with orthobiologics is when we treat a joint, we have to treat it holistically.
Great. And so when somebody says, I got an MRI and my doctor looked at it and I have a bone marrow lesion, I think that's important to define because we even, my wife actually practices in internal medicine and she even said, well, what do you mean by a bone marrow lesion? So describe what we mean by that.
So with the bone marrow lesions, and throughout the study, he noticed that the bone marrow lesions and their reduction in size, definitely reduced the knee replacement. So the bone marrow lesion is a lesion, just like the term says, within the bone. It's typically above or below the joint line where we'll see some sort of inflammation. There'll be weakening or changing in the bone. It can be a part of the normal arthritic process, or it can be associated with some sort of acute injury too. In regards to what we're looking at with this study with Hernigo, it's can be a part of the normal arthritic process where the bone weakens, becomes inflamed, and we do see those on MRI. Those correlate more with pain than cartilage loss.
Yeah, so that makes a really good point because we were definitely taught, okay, well, arthritis is the loss of cartilage back when I was in medical school, and that's the result of the pain. But I think a lot of us have found as we've gotten more experience that these bright spots, on this specific sequence of MRI and an otherwise dark bone is showing us that in a lot of ways, the thing that correlates more with pain than maybe a bad x-ray or loss of some cartilage is the bone that nourishes and sits right underneath that cartilage, which I guess is transforming the way we think about arthritis as a disease that really is a whole joint disease and not just kind of isolated to the loss of the cartilage. So what I'd love if you'd expound upon a little bit is, in this paper, Dr. Herniger really focused a little bit on what the underlying concentration of these MSCs or these mesenchymal stem cells were like in the joint fluid of a knee with arthritis versus inside of that bone, that area of the bone that's right underneath the cartilage. Talk a little bit about that and why that's important.
Sure. So, what they've found with evaluations of the synovial fluid is that the joint, when it's going through the arthritic process, is going to more than likely release local MSTs from the synovium and possibly from the cartilage and bone into the joint. So you're going to see a significantly higher level of these stem cells within the joint. And the thought being was, well, maybe if we place more stem cells within the joint, we would have an improvement in symptoms. And within the study, they did see that. Things worked pretty well with the injection into the joint, the intra-articular injection, for up to about 12 months. But after that 12 months, that's when we saw the difference from the other knee that was injected into the bone, where things changed from there on. And they also noticed that the MSCs within the subchondral bone were at a lower level than found in the joint. And that's what I guess, one of the quite surprising parts of reviewing this paper was the significant change in the concentration reduction within the subchondral bone within the knee.
Yeah, so I'm going to summarize just a little bit there. But so one of the big findings is that there were, in fact, some activated stem cells floating around in the soup inside of the joint of an arthritic knee. But where there were hardly any, or where there was a really, really profoundly low number, was in that bone that was just next to the cartilage. And so that may be driving some of our thought about how this disease develops and if we're going to do a procedure to try and restore, normal architecture, how we should do it. So, in light of that, I think one of the things about the study that was cool is when we look at the number of patients that we treat and we look at the number of them we treat with mild disease to kind of mild to moderate or severe disease, we break that down with a grading system. We call that Kellgren-Lawrence 1 through 4. It's been around for a long time. We generally tell people that, grade ones are very, very mild changes. Grade fours are kind of, that classical patient comes in saying, I've got bone on bone, which we would otherwise say it's end stage disease. And most of those patients, get joint replacement. And at least in my practice, I tend to tell all those patients to get their joint replaced. But even some of the patients in this study, seemingly a smaller number, but even some with end stage disease seem to have some success for a longer period of time that got the treatment into the bone. Why do you think that is? Or have you seen results like that in your practice? Or what do you think about that?
Yeah, well, over the past 4 years, if you give me a patient with, grade 3 to grade 4 medial compartment that has not had knee surgery,
And sorry,
um,
Eric, can you describe what you mean by medial compartment? What do you mean by
yeah.
that?
So on we talk about different compartments of the knee. You have the inside of the knee, the medial compartment versus the lateral compartment, and this is what his study focused on was on patients where their inside of their knee had the breakdown of the joint and cartilage loss and the synovitis or the bone marrow lesion. So when I see that patient, even if they are severe bone on bone grade 4, I am pretty confident that I can give them the results that we have seen in this paper. Um, and the thing with the arthritic population is that people are getting younger. So you see people in their late 40s with end stage disease. The knee replacements have their place, but if we can delay that for 15 years and maybe they're only having one knee replacement instead of having a revision, which, as you know, is probably not something you want your patient to experience.
Yeah, certainly the risk of complication and the risk of having extended days in the hospital, longer recovery, all those things kind of tend to track pretty well with having a revision surgery or kind of a second surgery, after a primary replacement. And I would agree. I think we see a trend that people are getting joint replacements at a younger age now. And like you said, I think the youngest patient in this study was 48. We do see people in their upper 40s going to get joint replacements. I saw a guy today in his mid 50s who'd already had a right hip replaced 5 years ago. So we're seeing it more and more. And 15 years is enough to really bend the needle. I think when you look at things that work for a year or a couple of years, then that's great. It can restore function. But I think the point of the paper is showing that if you can delay need for a knee replacement and not just that, but improve pain and function for a 15-year period, that's game changing. So
Yep.
especially at a fraction of the cost and without the need for general anesthesia. Now that brings me to another question. So for you in your practice, if you are taking somebody for a subchondral injection, do you tend to take those patients under general anesthesia or do they get sedation or a block, or how exactly do you do that?
Yeah, in our office, we're office based. We do majority of our procedures are office based. So our subchondral injections will receive IV sedation, Versed, and fentanyl. Prior to the bone marrow aspiration and right prior to the subchondral interosseous, the bone injection. The most people tolerate the procedure really, really well. There will be quite a bit of pressure sensation while you're injecting the cells within the bone, over maybe 5 seconds at each site. But otherwise, it's tolerated really well. There's limited to no recovery. Pain pills maybe for a couple days. They can ambulate right away. I typically have them do physical therapy, even though this study did not. But it's a pretty easy procedure for the patient to tolerate during a procedure and then after.
Yeah, and I think a lot of people, I appreciate that you make that point because a lot of people are really afraid. I think that if you're going to do any kind of injection, even if it's remarkably precise and it's image guided and it had a great local block beforehand, they're afraid that this is really going to hurt afterwards. And one of the things in the paper is that even though in this paper they did get general anesthesia, it said the patients didn't notice a difference. Like they didn't know because they would get one knee injected just in the joint, the other knee injected with the cells underneath the bone, but they couldn't actually distinguish the difference after the procedure, which I thought was really important because we do weight bear our patients right after. We don't restrict them in that regard. We also, like you, typically will combine a procedure like this with physical therapy, but a lot of that is because we're trying to address some of the other biomechanical problems that have gone on when somebody says, well, I used to walk 3 to 5 miles a day and now I don't because, my knee hurts me and, I want to get back to achieve some kind of goal. And so we typically are putting people through a program like that. But I think it's awesome that you guys are able to do that without sending people for general anesthesia, especially because, that's going to disqualify certain people who would otherwise either be too sick or who are not, wanting to take that kind of a risk. So, one of the things that I thought was really important is they talk in this paper about analyzing the number of cells, and they use a few different ways to do that. So they measured some different things called hematocrit, and they looked at cell counts and then plating these cells and looking at these concentrations. Talk a little bit with me about how you measure your cells to be confident enough that your patient is going to be getting a good long-term outcome.
Sure. So this takes back to another Hernigou paper about your technique on bone marrow aspiration. So we know we want to take the cells out of the iliac crest. If you're not taking the cells out of the iliac crest, you are not doing a proper bone marrow aspiration procedure.
And then you mean specifically the back of the hip bone, correct?
Correct.
Okay.
In this procedure, I believe he took them from the anterior crest. And so that's number one. And then there's a special technique involved in using a smaller syringe, a quick aspiration, and then the concentration of the cells. I think most of us are probably doing a double spin technique. I'd have to go back and look at his earlier papers. I think he's getting a higher volume, probably on a single spin. So that's one of the other things that I've adjusted with my practice over time was increasing my volume of injectant. So you are getting a better spread throughout the bone. And you can do that a variety of ways. Some people like to combine just bone marrow aspirate with the bone marrow concentrate. I like to take some of the plasma and concentrate it because there's proteins in there that can help with the healing process. You can also use some other devices that'll give you a quote unquote a clot, which may help in the healing process also. So there are techniques where you can refine your process, but number one starts with a good aspiration. Once again, Dr. Hernigou has shown us how to do that.
Yeah, and you're talking about some very technical things there, which maybe not the average person who walks into the clinic would understand. But I think you're talking about whether or not you just pull some cells out of the bone marrow without spinning it down in a centrifuge, or sometimes you do, and then sometimes you use some of the other maybe the fluid or the plasma that comes out to do different types of things. And certainly, I'm a believer that you should be doing that, tailoring to the specific kind of pathology that you see. I think when we're talking about procedures like this, and we're talking about how we measure it and how we quantify the number of cells that you get and being confident that you have a good injection, we've also got to have conversations about the flip side. And that is, what is the real risk to a patient here? And at least in this paper, and similar to what we found in our practices, there were no reported adverse events or serious events. And I think when you're weighing that against, something else that could potentially be, not only, disabling, but maybe even life-threatening, that's something that needs to be stressed as well. Um, when we were looking kind of at some of the increase, so when we're quantifying cells and we're increasing them, it was amazing that what Dr. Hernigou specified was that when they injected these concentrated cells back into the joint, it looked like they were increasing, the number that was sitting around the fluid, sometimes 5 times as much, sometimes even up to 20. But really, when they put it in the bone, it was going up from 60 times as much to 200 times that underlying cell concentration that's inside the bone. Why do you think that contributes to such a dramatic outcome over time, over that longer 15-year period?
Well, I think it's a few different things. So, I think we've seen this in other joints too, be it the hip or the ankle, is that as you age in those bones, the population does decrease some. So I think what you're doing, number one, is you're stabilizing function of the bone. I think you're also mechanically stabilizing, so it's allowed to provide the appropriate nutrition to the joint space. Um, you're taking them from an area where there is a higher concentration in iliac crest, and then, as you said, the 60 to 200 times. The cells that we're transplanting there are talking to the local environment, telling them to wake up. You got a job to do here, take care of this knee, but they're also working in different effects by, be it an autoimmune, anti-inflammation, or pro-growth. Last year, I probably wouldn't want to say, hey, I can, improve your knee in regards to cartilage regrowth, synovial improvement, or bone marrow changes. With a study like this and other ones that are coming out, I'm confident saying that now, that we can actually change your disease process. This study also showed the reduction in the size of the bone marrow lesion, the improved synovitis score, the increase in cartilage, whereas the population that just had the injection into the joint didn't see that. And they also didn't see the changes in x-rays. So there wasn't disease progression on the knee arthritis score from x-rays. It was just an amazing study all around. And it still blows my mind that he was doing this 20 years ago.
Certainly before we were doing it on average in the United States. I think when you talk specifically there, you mentioned kind of earlier patients that were getting injections in the joint had maintained pain reduction out to a year, but that the subchondral, the inside the bone injection, it was going, multiple years. And why was that happening? And I feel like we as physicians, we're happy when we see pain reduction and clinical improvement, but we really want that feeling of objective information. And that's why getting able to look at an MRI of somebody 2 years out, multiple years out, that's showing, yeah, not only do you not have more joint narrowing, but you actually did have, even if it was a small amount, improvement in the cartilage surface, or at least suggesting that we're stopping the progression. And that was unique, like you said, to the injection inside of the bone, as opposed to the injection in the joint, where we still, it looks like over time throughout his study, still saw progressive narrowing from the injections in the joint, but not the ones inside of the bone. So when you talked about the reduction in the bone marrow lesions, I mean, have you, we sometimes tell people, oh, you had an injury. We can tell that there's a lot of swelling in your bone. And maybe you've seen that patient back, years later for another problem. Uh, do you see, or have you in your experience seen those bone marrow lesions or kind of that swelling in the bone going down over time, or is that uncommon for you?
I'm typically not ordering post-op MRIs as
Sure.
this patient did. Now, if it's an ACL and I want to see if the fibers are, aligning, then I'll typically order that. If it's a disc tear and I want to see if I've sealed that disc at, 6 to 12 months, then I'll order it, or a rotator cuff to see if we got a tendon coming along. I've currently, my practice, I'm not doing it for the bone marrow lesion, but it, considering what his study showed, maybe you missed a little bit of the cells in the lesion and you need to adjust your technique a little bit. If I have a younger patient that's coming in their early 40s to, early 50s, then I'm typically, and they have severe pain, I'm going for that MRI pretty aggressively to look for that bone marrow lesion. Now, if you're 60 or 70, you're walking into the clinic, I'm not ordering that. And I'm fine with the x-rays and putting the large volume in the inside of the knee, in the bone, above and below the joint.
Yeah, so it sounds like age and severity of pathology maybe play a little bit into that. And, I would agree. I think, a lot of patients, I have patients who will ask, because they are curious and they want to know. And they say, well, if I'm a year out or 2 years out and I'm really doing great, are you going to get a follow-up MRI, or do I need one in 6 weeks? Or, when do I get follow-up scans to see how well I'm doing? And I usually kind of tell them, well, I'm like, we don't often get repeat studies if somebody's doing well. I mean, we get
Mhm.
repeat studies if they're not doing well. Of course, if you're in a research study, it's a little different. But similarly, we don't have a lot of those unless there's another injury or there's something else that goes on in the future. I think just to summarize too, when you look at kind of the time across which people received follow-up scans in this study, the specific quote was 60 patients who got injections inside of their bone. 80% of those people did not get a knee replacement 14 years out, and
Yeah.
20% converted with an average rate of about 1% per year, which obviously is less than 1%, obviously, if you look at the data. But so around one person a year. And then I think that rate was up to 70% at a mean of 7 years for people who just got injections in the joint. So that's pretty impressive. So one of the things I would ask you about too is that, it looked at some factors that increased risk for people to end up needing a knee replacement over time, or other things that decreased it. Um, will you talk about how that affects, what you do as far as how you counsel a patient?
Yeah, so I think in this study specifically, I think he saw gender bias for women. I think your BMI, your general health, and then if there's deformity around the knee, if it's still the grade 4 and the angulation above and below the knee is pretty straight, I think you got a pretty good chance. The other thing that calls into question is what else can we do for the patient prior to the procedure? I think that's one part that we're still learning about. How can we improve their general health, improve their stem cells through diet, through exercise, through blood flow restriction therapy? What else can we do to hopefully get them the best outcome possible? And I think we're most of us are going more to adding that to our practice. I think the procedural care is probably pretty standardized now for people that are doing this across the country. Is what else can we do to make you healthy, to improve your own stem cells, so we do get that higher concentration that he showed in this paper that has a better outcome.
Yeah, so certainly some of it has to do with our technique and our training, but other parts of it have to do with, can we look comprehensively at someone and say, this is not just about relieving your pain. This is about, getting your BMI, or your body mass index, which is a way that we measure obesity, getting that better controlled. How do we get you back to meaningful activities? How do we make sure, I think diabetics were excluded, so how do we get blood sugar under control, and partnering with primary care physicians, and other experts throughout, I think, the clinical regimen to be able to do that. It's funny you mentioned blood flow restriction. We do actually do a lot of that here in our post procedure rehab, and I kind of have this discussion with patients about whether or not, we have some ideas about whether there's some kind of synergistic effect. And we were studying that at the Andrews Institute where I used to work, but didn't leave with a compelling sense that there was hard scientific data to say, well, this definitely makes a difference, long-term outcomes. But, especially the military guys in particular, they all want to get BFR and get BFR done because they,
Mhm.
have talked to guys or read about stuff that says, yeah, this makes my platelets better or my cells better. So, the other thing I would harken back to is Dr. Mishra on a prior show also said, unfortunately, for a lot of patients, and he said he doesn't do joint replacement anymore, but he had said that after they get knee replacement, even if they were more functional, a lot of times 2 years later they were actually heavier than they were when they came in. And so it kind of begs that question of, well, what is the purpose of trying to help? I mean, certainly it's to relieve pain and restore activity, but also to work on kind of the rest of the patient's general health. And I think if we're trying to do procedures in a vacuum and not take that into account, then in some ways we're kind of missing the point when it comes to the care of the patient. So anything else that you say to your patients, Eric, when they're concerned about pain or risk of the procedure, or are they too old to have a procedure, or how long am I likely to expect a result? How do you counsel them when they come in and talk with you about it?
Yeah, I think my oldest bone marrow intraosseous procedure was on a 90-year-old that did
Wow.
very well. We have some in the 30s or the 40s. Most people want things to feel better right away. And that's one of the things I counsel on. So this procedure is going to take time. I usually tell them, give it 3 months. And I think over that time, you will notice gradual improvement. Now, there are those knees that are, the joint or the synovium is really inflamed, and they may, even though they are severely degenerative, they may improve rapidly within 2 weeks. But that's not the norm. So I definitely tell them it's going to take time. Stay away from the anti-inflammatories over that 3 months. Let's get you in physical therapy and leading that healthy lifestyle. And more times or not, in the specific population that was in the study where the inside of their knee is giving them the pain, if we inject you in the bone, 80% of the time, you're going to be pretty happy.
Yeah, that's great. And then does anyone ever ask you, just in closing, how long do these cells actually survive inside of my bone when you inject them in there? How long do they stay in there, and how long do they survive? Does anyone ever ask you?
I haven't heard that one. In regards to I think my first procedure for a bone marrow stem cell was a disc. And there are some studies where they stained them and they went back and checked multiple years later. So I think they're staying around in the bone. If you take a look at the disc studies, multiple years. I don't know. Do you know more about that?
I tell them I don't know, and I tell them what the research and the outcomes data is, and obviously if I can say, look, I don't really know how long they're sitting in there, but what I do know is that if we do a great procedure for you and we optimize your counts and we do everything correctly and we put these cells, use the x-ray machine and we put them exactly where, the lesions are on the MRI, and these are the success rates, and we can buy you 15 years of relief. I may not know all the answers, but I know what can get you to a place that you haven't been able to achieve so far. So usually that's the discussion I have. I'm trying to be pretty transparent with my limitations. So, well, that was fantastic. I really appreciate you sharing your practice with us and talking about how we can change the way that we improve the treatment of knee arthritis, not only here in the United States, but across the world. But I'm going to introduce, obviously, your website and how patients can find you. But any last comments you wanted to add, Eric, in regards to the treatment of knee arthritis or the practice of orthobiologics?
No, not this time, Trevor. I really appreciate being on the show. It was great discussing this wonderful study with you. Our website is michiganpain.com. We have multiple locations in West Michigan. And give us a call if you have any questions.
Great. Thank you so much for being on the show. We appreciate you guys joining us for episode 6, season 2 of the Orthobiologics podcast. Again, I'm your host, Dr. Trevor Turner, MD, RMSK. You can find us at georgiaboneandjoint.org, where you can book online conveniently, or check us out on Facebook or Instagram. Thanks for your time.